So let's see what's going on in this image. At this point in time, there's a very hyperemic border. So this is a very pale area surrounded by a lot of red. This is very red here, as you can see, which we call hyperemic. Why do you think this happened? Remember, we said that we initially made a lot of hypoxia-inducible factor due to the hypoxia, right? This led to the release of vascular endothelial growth factor. What do you think this red is from? Vessels are trying to grow into this infarcted area, like so, and that gives it a very red, hyperemic border due to the vascular endothelial growth factor. Vessels finally start to grow into this granulation tissue, and it starts at the borders. And this is for the very nice red border. When the whole process is complete, you're still going to need blood supply to this area, even if it's a scar. The area is nice and yellow on the inside because neutrophils and dead myocytes look yellow, in addition to some of the extracellular matrix. This area is very soft and weak. It's dead cells and newly formed, disarrayed extracellular matrix. In addition to that, macrophages have been munching on it, trying to clear that necrotic debris out, because that's what the neutrophils told them to do. The neutrophils broke it all down, and the macrophages need to come in here and clear out the necrotic debris from the dead myocytes and also the dead neutrophils. This is a particularly high yield stage. Focus in here. Gotta listen on this. You think about it like a macrophage is like Pac-Man. So here's our Pac-Man, just munching on everything, right? Macrophages going all around this infarcted tissue in this area, chewing up the necrotic debris around this already weakened myocardium. Do you think that this wall is as strong as normal tissue? No way. This weakness greatly increases our risk for rupture. Where the rupture occurs depends on which artery you infarcted. For example, an infarct in the left anterior descending puts you at risk for developing a rupture in the anterior 2/3 of the interventricular septum, the anterior wall of the left ventricle, and the lateral wall of the left ventricle. And that's because you're including the marginal branches that come off the LAD. Remember, there's dual perfusion in a lot of patients from the marginal branches off of the left anterior descending and the branches that supply the lateral wall from the left circumflex. So let's visualize this with a cross-section of the left ventricle. So here's our left ventricle, LAD, we can infarct the anterior left ventricular wall, some of the lateral wall, and the anterior 2/3 of the interventricular septum. So here's the anterior 2/3 of the IV septum, anterior wall, and our lateral wall. So let me repeat that. An infarct in the LAD puts you at risk for rupture of the anterior 2/3 of the interventricular septum, the anterior wall of the left ventricle, and potentially the lateral ventricular wall. And that is because we include the marginal branches that come off. So, if you rupture the interventricular septum, what do? You have created a VSD. Now what if you infarcted the posterior descending artery? What does that come off? The right coronary artery, right? You would probably have decreased blood flow to the posteromedial papillary muscle. Why? Well, what does the posteromedial papillary muscle do? It is posterior, so it attaches to the posterior leaflet of the mitral valve. Let's visualize this. So again, here's our chamber, and this is a cross-section. So here's our myocardial wall. This is heart muscle cut and reflected back. And here's a papillary muscle. Here's another papillary muscle. And here is our mitral valve. And there are little cords that extend from the papillary muscle that attach to each leaflet of the mitral valve. These are called chordae tendineae. This is the posteromedial, because it's medial and posterior papillary muscle. This is the anterolateral, because it's anterior and lateral papillary muscle of the left ventricle. So we are in our left ventricle. So the mitral valve, this is the posterior leaflet, obviously because this is the posterior medial papillary muscle. And this is the anterior leaflet, obviously because it is held with the chordae from the anterolateral papillary muscle. Now what does the posteromedial papillary muscle do? It's posterior, so it attaches the posterior leaflet of the mitral valve. It prevents the mitral valve leaflet from ballooning up into the left ventricle, so it doesn't go this way when we have systole. But if you cut off its blood supply, it's probably going to die as well. And as future doctors, we like to call this papillary muscle rupture. This is another potential complication of attending a Justin Bieber concert and suffering a myocardial infarction. the mitral valve leaflet will have nothing holding it back. It can just flail all the way back up into the left atrium during systole. You can have an acute, the key word there is acute onset of mitral valve regurgitation because you blew out your posteromedial papillary muscle from occlusion of the posterior descending artery. Can you name some other potential complications that occur at the 3 to 14 day window after a myocardial infarction? Cardiac tamponade. Why? So let's visualize this again. We have our fibrinous pericardium, and then it reflects over on itself, and this is the visceral layer of the epicardium. Under that is the myocardium. Under that is the endocardium. So let's say we had a transmural infarct. Well, we infarcted the endocardium, the subendocardium, the myocardium, and the visceral layer of the epicardium. The only thing still alive is this outer fibrous, very strong epicardium. Blood will push through all of this because we ruptured our wall because of complete ischemia. Blood will just push up through this newly formed lumen into this pericardial space, and we will just start accumulating blood in this area. This leads to acute onset of hemorrhagic cardiac tamponade. Really scary, really bad. You will have to do a thoracotomy on these patients where you go directly in through the chest wall and cut the pericardial sac to save their lives. Can you name another potential complication at the 3 to 14 day window post myocardial infarction? How about a pseudo aneurysm? Why am I calling it pseudo? Well, pseudo means false, and Greek aneurysm means dilation. So this is a false dilation. Why would someone form a false aneurysm after an infarction? So first let's talk about what we know. A true aneurysm, not false, must involve all three structures of a vessel, or in this case the myocardium, all three layers. A pseudoaneurysm does not do that, okay? A true myocardial aneurysm does not have only a couple of layers involved. So for example, a pseudoaneurysm looks like this, where this endocardium, the myocardium, and then this epicardium is still holding on for dear life, but there is a lumen and the epicardium is ballooned out and only a little bit of fibrous tissue is holding on, allowing this false aneurysm to continue to grow in size. So we are not in the time frame to be at risk for a ventricular aneurysm because we need complete fibrosis for that. Remember, a true myocardial aneurysm does not look like this image. A true myocardial aneurysm is scarred and fibrotic wall without necrotic muscle that is a result of a healed transmural myocardial infarction. Again, we are not in the time frame to be at risk for a true ventricular aneurysm because we need complete fibrosis and resolution for that. On the other hand, in this 3 to 14 day window, we are definitely capable of having a pseudoaneurysm. So, let's look at this image. As you can see, there's only one layer within the wall of the aneurysm. It is called a false aneurysm for this reason. During our acute MI, we infarcted the endocardium, the subendocardium, and the myocardium, so this tissue is gone. There is no endocardial or myocardial layers. They're obliterated. There's a new lumen here that's allowing blood to accumulate within this false aneurysm. The only thing holding this false aneurysm from completely exploding are the fibrous adhesions within the tough layer of the fibrous epicardium. Now, this narrow neck communicates directly with the left ventricle. Blood can go in here constantly. This communication allows blood to accumulate in this space. The blood flow within this aneurysmal sac, false aneurysmal sac, is very low, and we can actually plug the defect at the opening of the aneurysm with a thrombus, so we can get a thrombus forming here. The nomenclature might be confusing because we classically hear the term mural thrombus being thrown around with a true, not false aneurysm. But the thrombus that we form here that just temporarily blocked this lumen that was formed from ischemia is also associated with the formation of a mural thrombus. There's a thrombus forming in the wall, right? It is not the classic mural thrombus that you see with a true ventricular aneurysm. I will explain this later, but the main thing you need to know about a pseudoaneurysm is that it is an incredibly high risk for rupture. All that's holding on are these little fibrous strands. Because there's only one weak layer left holding on for dear life, you have a high risk for rupture. So let's step forward in time and examine some things that can occur after we have hit the 2-week mark. Alright, great. We did an excellent job with the pseudo aneurysm. Let's look at this image and visualize what is going on a macroscopic or gross level. So after our macrophages went into the infarct and cleared out all of the debris, including dead myocytes and dead neutrophils, they released some transcription factors. Remember? They released TGF-beta and platelet-derived growth factor. These tell fibroblasts to come in and start positing the tissues that fibroblasts make, which include what? Collagen. Because some type of stronger tissue needs to replace the area that is just necrosed and has been cleared out. There is no longer any viable myocytes within this area of the heart where we saw necrosis. We now just have scar tissue, which is replacement of previously viable myocardium with fibrotic scar tissue. It appears grayish-white on gross examination, but under the microscope you can see a different type of coloration. Obviously, under hematoxylin and eosin stain, collagen likes to stain pink. This is an old scar months to years after a myocardial infarction. It shows us a large area after the infarction at around 1 month. Notice how there are no myocytes. There's just a bunch of collagen deposited. We know that collagenous tissue appears pink. Notice how there are no myocytes. Again, remember, that's what happens. They get cleared out and replaced with scarred fibrotic tissue. Do you think that this scarred tissue has any contractile ability? No, there is no contractile ability. This area with no myocytes is hypocontractile or hypokinetic, meaning that it does not contract and participate in the ejection of blood with the rest of the viable ventricular myocytes. This is particularly unfortunate because if there is a segment of the heart wall that is now collagen instead of viable myocardium, it is going to be just like a bed sheet flapping in the wind when the rest of the heart contracts. So this area is particularly weak and can bulge out when there's a sufficiently high enough systolic pressure. Wait a second, we talked about this earlier, right? Yes. This is how we develop a true, not false aneurysm. If this occurs over time, then we can actually get a true aneurysm in which there is a ballooning out of all 3 layers of the heart. Your first aid book tosses in the word dyskinesia next to a true aneurysm. Why do they include that term? It's a fancy term for describing the paradoxical ballooning out of the scarred area when the rest of the ventricle is contracting inward to eject blood. So a great way to visualize this is to imagine holding a small water balloon in your hand and then you squeeze it. Some part of that balloon is going to pop out of the palm of your hand just because of the way that it is going to change shape when you press down on it. So for example, if this is our left ventricle, when this squeezes down, this scarred tissue here is going to balloon out because it is not able to contract on itself. Instead, it is going to be pushed out by the pressure that is created by compressing the blood that is within the chamber. So the pressure will push out this scarred segment, and that is how you can get a true aneurysm. What is super, super high yield is the next question. Do we need to worry about rupture with a true ventricular aneurysm? No, no, no. We only worry about rupture with pseudo aneurysms. Remember, the difference between a true aneurysm is that it is composed of all 3 layers with a very tough scar tissue component, as opposed to a pseudo aneurysm, which is just the false aneurysm created from blowing out the myocardium and the endocardium, and there's a small fibrous adhesion holding in this blood that is accumulating in that last layer of fibrous epicardium, holding on for dear life. Incredibly high risk for rupture in a pseudoaneurysm, very low risk in a true aneurysm. But we need to worry about that hypocontractile element, particularly in the true aneurysm. Now, this hypocontractile element is a real problem for us. So again, you have our ventricle. This area can bulge out because it is only made of collagenous tissue. All those myocytes are dead. That is why we did not see any on the microscopy. So this area bulges out instead of in during systole, and blood can actually pool in this segment. There is no contraction going on. It is a very static environment. Whenever you have blood in a very static environment, you set that blood up for clotting. So blood will collect within this ballooned out segment that is hypocontractile, hypokinetic. This is the perfect formula for clotting because there is blood that is not going to be ejected out of the ventricular outflow tract. It will rather just sit in this segment here of ballooned out collagenous tissue. This is called a murothrombus as well because it literally forms on the wall of the hypokinetic segment. The thrombus forms due to stasis. This is the classic murothrombus that people describe. Remember, we can also see a murothrombus associated with a pseudo aneurysm, but that is a thrombus that actually forms to cover the defect, as opposed to this is a thrombus formed in the pooled segment of blood within the hypocontractile hypokinetic segment of fibrotic myocardium. Forming a huge clot in the chamber that pumps blood to the rest of your body is a slight problem. All that has to happen is for a couple of pieces of this thrombus to break off, embolize, and now we're throwing clots everywhere. As important as that is, the high yield element of the post-MI 2-week period and onward is something that is super high yield because it ties in immunology. It is Dressler syndrome. Pathophysiology of Dressler syndrome relates back to the initial period when the macrophages were phagocytizing cardiac tissue. What do you think might happen if your immune cells are consuming your own necrotic cardiac tissue? Well, macrophages are antigen-presenting cells. They're a jack of all trades. They do so many things. So, a macrophage is an antigen-presenting cell in addition to a phagocytic sort of trash man. All that needs to happen is that your macrophage makes a mistake and says, oh, maybe I should present this cardiac antigen on my major histocompatibility complex type 2. And what does that do? Well, a T cell is just happen to be strolling along in the neighborhood and it picks up this signal, and then you get an activated immune response targeted against whatever cardiac antigen your MHC2 complex was presenting on that macrophage membrane. This is a unique situation. Guess who loves to ask about unique situations? Your test question writers. So, you better know Dressler syndrome, and you better know how it is an immune-mediated attack on our own cardiac tissue after we suffer an MI approximately at least 2 weeks.